people so far. It's my name is Sharon Wasserman Swerdlow, for those who don't know me, and I'm privileged to be the president of the LA chapter of HLAA. And welcome everybody, both those from our chapter and guests and those from surrounding chapters. We're so excited to have you and happy to be meeting. Hopefully it won't be too many more months that we have to meet this way, but glad that we have this option. And we are very excited to have Dr. Elena Bassett with us today, who will be presenting to us on the vestibular system. Dr. Bassett is the director of the Balance Center at USC, USC Caruso Department of Otolaryngology. It took me a very long time to be able to use it, so now I like to use it when I can, and is also an assistant professor in audiology. And she will be giving her presentation, and I'd like if everybody can mute themselves during the presentation, and the Q&A will follow the presentation. So if she can get through it, and then we'll save up your questions and write them down and we can ask them after, that would be terrific. And I just want to mention that we will be recording the presentation so that it will be posted. So for those who want to see it again or share it with friends or family, you'll be able to see it after. But we're going to start recording as we're going to be recording it. So anyways, with that, I'll turn it over to you, Dr. Bassett. Thank you so much for joining us on a Saturday morning.
Well, thank you for the warm welcome, Sharon. I was so incredibly excited to be invited to come and speak to your group about the vestibular system. And it's great to start my Saturday morning seeing a few familiar faces. So if I know you, I am so happy to see you this morning. My name is Elena Bassett, and I am the director of the USC Balance Center. And I am an audiologist who specializes in the vestibular system. And my passion for the vestibular system grew in my experience at the University of Nebraska-Lincoln. So I'm actually a Cornhusker. So Tim and I started our conversation this morning talking a little bit about the Midwest and being from Nebraska and Iowa. I have my Nebraska Go Big Red coffee cup this morning, which got me ready for today's presentation. My interest in the vestibular system grew actually from my exposure to managing balance and dizziness post-concussion for athletes. So if an athlete at the University of Nebraska sustained a concussion, they would come and visit with our group, and we would assess their balance function related to their head injury. And you may be thinking, well, how are the inner ear and concussion and balance and dizziness related? And that's how I hope to explore that topic with you this morning and kind of give you an opportunity to think about your ear, not just only as an auditory system, but also as your brain's accelerometer and GPS, helping you decide where you are in space as you move through your day. I currently work at the Caruso Family Center for Childhood Communication, evaluating balance function regarding dizziness, unsteadiness, and imbalance across the lifespan. So I see patients from age 4 to 104 because we can all have balance concerns at different ages and different stages. My favorite balance activity is yoga. And I think we all might have a favorite balance activity that we don't realize. There's something about stretching and moving your body and exploring what your balance can do that's incredibly rewarding for me. So when we think about our balance system, it's more than just your inner ear, which is your vestibular system, if you were not aware of that. It's our visual system and then our somatosensory system. Our vestibular system, we'll go into detail today, is the accelerometer of our head, telling our brain the position of our body in space as we move through our day. Our visual system gives us an opportunity to see our clear visual path as we're moving through our environment. Is there a chair in our way? Are we going to walk into the door frame? Is there a dog that's running across our path where we need to change the way that we're walking and moving? And our somatosensory system is the sensation in our feet and ankles. How does the ground feel beneath our feet? Are we walking on a firm surface? Are we walking on sand? Are we walking on a trampoline? All of these different types of surfaces mediate the way that our muscles respond to help us keep us upright. So our balance system is not just one part, but a triangle, 3 parts combined And changes in any piece of this system can result in symptoms of imbalance. So I'm going to dive into each part for you today because balance and symptoms of dizziness require kind of a holistic look at you as a person, not just looking at one part, but looking at all the parts to decide, okay, how can we help you better navigate your environment and keep you safe from adverse events such as falls? So we're going to dive into the inner ear or the vestibular system here to start. And I'm showing you this model of the ear, and you are most likely well versed in it. We have our outer ear shown here, our external ear, what we can see on the outside of our heads, what we consider to be the classic ear. And sometimes we don't necessarily have the traditional ear on the outside of our head, but we can still have an inner ear that allows us to process sound. We have our middle ear space, which includes the stapes, incus, and malleus, the bones of our middle ear that help us take the acoustic auditory signal and pass it and transfer that energy to our inner ear, which includes our cochlea or our hearing organ, which we spend majority of our time discussing if we are involved in audiology, as our auditory system allows us to connect to others through communication and allows us to hear environmental sounds. But in that inner ear as well, you may have always maybe been curious about what this system is here. And I'm circling it vibrantly here because I drew a lot of other little circles. So I want you to focus in on these hula hoops that you may see in this upper region, where you may have been curious or may have known that that perhaps has to do with balance, but maybe aren't sure what that could possibly do with balance function. That is your vestibular system. And your vestibular system is designed in order to process the movement of your head as you are going through your day. And in processing the movement of your head, is able to coordinate your visual system and your somatosensory system, the sensation in your feet and ankles, to keep you stable and to keep you safe. When we consider the vestibular system, we have two sets of 5 organs to the right and left side. Our vestibular system is composed of 5 parts. We have 3 semicircular canals and 2 otolithic organs, and we're going to talk about each. The semicircular canals are the hula hoops that you see, those open circles that are designed to actually interpret angular motion of the head and respond to acceleration of your head as you move through your day. Our otolithic organs, known as our utricle and saccule, respond to linear acceleration of our head. I'm moving forward and back on a skateboard. I'm riding up and down on an elevator. This angular and linear acceleration, or linear and angular movement, allows us to capture head movement in every plane and in every motion as we are proceeding through our day. It's a complicated system, but its goal is to capture information in order to better coordinate our visual system and better coordinate the overall response of our body so we can stay safe and stay aware of different types of events and or factors that may influence our balance function in our environment. We note that our semicircular canals, or the semicircular canals and the utricle and the saccule, are not only talking within each other to one side of our system, but also communicating across the brain, across the head, to the opposite side. And so this communication within and between is a constant that is something that cannot be manipulated, but can only be manipulated by a change in function, whether it be related to a disease process or related to aging. The only thing that the vestibular system responds to in the healthy kind of frame is gravity and angular movement. So to manipulate the vestibular system, we typically see a few disease processes, and we'll talk about those today. But I wanted to dive a little bit more into like, well, how does this system actually function? What does it mean when you're processing angular movement of your head? That does nothing for me. We've all spun maybe in an office chair, or have all tied ourselves up in the slide, or excuse me, tied ourselves up on a swing and released it and let ourselves spin around. And that type of intense movement that you've experienced is being processed by your vestibular organs. The acceleration and the constant spin is being registered by the system. And that is why when you stop, you can feel the world bouncing in front of your eyes. You can feel some symptoms of motion sickness or intolerance, because our brain and our balance organs are registering the fact that we were in motion, and it's not matching what we see or what we can feel. Our angular motion of our head is registered, like I said, by our semicircular canals. And our semicircular canals are designed in a way where they only respond to motion. They're not necessarily responding to the pull of gravity. So with that, if we think of the semicircular canal design, it is actually like almost an egg, where we have a hard, bony shell and a soft, membranous interior. So that hard, bony shell is shown here, and it's a tube which holds our membranous labyrinth, which is filled with fluid. This fluid-filled space allows us to move the head and move the fluid according to our head movement. This fluid-filled space is filled with something called endolymph. And endolymph can push and pull on the sensory system within the semicircular canal to allow us to register how exactly we are moving our head and to which plane we are moving our head. If you move your head to the right, you are stimulating your right horizontal semicircular canal. If you're moving your head to the left, you're stimulating your left horizontal semicircular canal. And the stimulation is occurring because of the movement of fluid. It's important to know that the fluid is pushing on a region of the canal known as the cupula. This cupula serves as a sail. It almost like catches a breeze, like the billow of the wind on a sail, pushing it one direction or pushing it at the other direction, depending on the fluid. If you're familiar with the cochlea, we know that we have sensory hair cells surrounding the entire cochlea that are specific to certain frequency ranges. In the vestibular system, we do not have in the semicircular canal hair cells lining the entire canal that are moving with the fluid. Instead, we have a region of sensitive cells embedded in the cochlea. And as the cochlea is pushed in one direction from the fluid or pushed in the other direction from the fluid, that is how we register information. An example of those hair cells is shown here, where the cupula is a gelatinous membrane that stretches up on the semicircular canal and connects like a string, a tie, where our hair cells are embedded with that. And as the cupula is pushed, the hair cells will move and register that your head is in motion. So like this, we are pulling and pushing the hair cells, causing excitation where we're registering that we're moving our head to the right, and inhibiting, registering that perhaps because we're moving our head to the right, we are exciting the right side and inhibiting the left side. And this difference in electrical firing allows us to register where our head is actually in motion too. It seems like a complicated little piece of the system, but I think it's important to know that as you move, the electrical charge is changing throughout the day. And that is how you're able to interpret how your head is moving through space. The otolithic organs, the utricle and the saccule, do not behave like the semicircular canals. In fact, they respond to linear motion alone and are very sensitive to gravity. Our utricle, shown here, is positioned about 30 degrees upwards within our vestibular system and is responsible for interpreting information in a linear plane forward and back. Like I'm moving forward and back on the conveyor belt at the airport when you're going to move to the next terminal, which is a place maybe not a lot of us have been within the past year, or we're moving forward on a skateboard. The saccule, shown here, is responsible for interpreting information up and down, like I'm jumping up and down on a pogo stick, or I'm moving up and down in the elevator. This movement is based off of gravity and the pool of actually what we call otoconia, or crystals that rest within the utricle and the saccule. These crystals are sensitive to gravity. And as we tilt our head, just like you would tilt sand in an hourglass, we know that the sand falls with gravity. The same thing with the otoconia. As we tilt our head, it pulls down on the organ and causes us to have an excitation or an inhibition of that system. These crystals are famous for all the wrong reasons, because they're typically associated with a type of dizziness known as benign paroxysmal positional vertigo, or Bppv. Bppv is one of the most common types of dizziness. And what happens is that these otoconia, or crystals, become loose from their position in the utricle or the saccule. And as a result, will unfortunately end up in our horizontal canals. We'll go back here, where they do not belong. When we have symptoms of Bppv, or benign paroxysmal positional vertigo, we will often experience symptoms of dizziness that last for seconds to a minute in duration, typically a true spinning or vertigo sensation. This type of vertigo is triggered by changes in head position. When we tilt our head up or when we tilt our head down, when we're rolling over in bed. This is because the debris or the otoconia is pushing the fluid inappropriately and causing us to trick our brain into thinking that we are turning our head. This type of dizziness, or Bppv, or benign paroxysmal positional vertigo, or Bppv, is often treated with different maneuvers, such as the Epley maneuver or the Semont maneuver. And you may have experienced it before unknowingly, or you may have been treated for it in the past by either your physician or your physical therapist or your audiologist. So know that this type of disorder is related to the fact that we have misplaced this otoconia and have had it end up in a portion of our vestibular system that is not supposed to respond to gravity. The Bppv prevalence increases significantly with age. So with every decade of life, your chance of experiencing Bppv increases significantly, unfortunately. As a result, we are curious, is the prevalence of Bppv related to perhaps some wear and tear of this system, where the fine fibers holding the otoconia break or shear in some way. And as a result, this bed of crystals falls into the horizontal or falls into the posterior or the anterior canal to cause us to feel increased symptoms of dizziness. We have different nerves that send different parts of information from our balance organs up to our brain to be processed. And the nerves are important. There's a superior nerve and an inferior nerve. The superior nerve is responsible for 2 of our horizontal canals and our utricle, while the inferior portion of the nerve is responsible for 1 of our semicircular canals and our saccule. And this labor is divided between the 2 groups. This division of labor is something that your audiologist or your physician is looking at when they look at your test battery and your test results. Are we getting healthy responses from one portion of the nerve and abnormal responses from the other? Because the system is divided like this, we can have changes in vestibular function, but that doesn't mean that we lose all 5 organs to one side or all 10 organs as a whole. We perhaps may lose a portion of the nerve, meaning that the organs associated with that nerve are no longer able to send information up to the brain. So this division of labor is actually like a healthy fallback that our body has developed in order to protect us in a way and keep vestibular function, even if we are to have a change in one portion of our system. I think that changes in vestibular function are often hard to identify because we are not good at describing dizziness sometimes. Dizziness is a catch-all for a lot of different types of concern. And if you visit with your physician, or if you visit with another healthcare professional, the way that you describe your symptoms often drives who you're going to visit with first and what your care path is going to look like. The symptoms of vestibular dysfunction or concerns with your balance organ can often be described as vertigo. But vertigo is a very specific type of dizziness that often gets tossed around quite a bit. So I'm going to go through some different types of descriptors. And if you've experienced dizziness as the catch-all in the past, perhaps it'll help you give a better idea or a better understanding of what you have experienced. For patients that visit with me at USC, I'm often maybe the 4th or 5th provider that they visited with for their symptoms of dizziness. And that's not because necessarily they wanted to go to all these different people, because we don't necessarily want to spend all our time at the doctor's office, but it's because we had a hard time figuring out where their dizziness was coming from based off of the descriptors that were provided. The 5 types of dizziness that I want to discuss today include the actual definition of dizziness, and that means a disturbed or impaired spatial orientation without a false or distorted sense of movement. It's often referred to as giddiness, lightheadedness, or non-specific dizziness, but does not include vertigo. This is the type of descriptor I would use when we just don't feel like the world around us is quite stable, or we feel disoriented within our space, or we feel as if we're having difficulty navigating our environment because the world around us is not necessarily how we remember it, or the way that we're interacting with the world around us seems distorted in some way. 2 other descriptors that I would identify more with perhaps a cardiovascular concern related to your symptoms of dizziness include presyncope and syncope. Presyncope being the impending sensation of the loss of consciousness, where you feel as if you may pass out, you may lose consciousness, you have significant lightheadedness. We all maybe have experienced this when we have risen too quickly from a seated position, and we feel that wave of woozy lightheadedness where perhaps our vision narrows for a moment and we have a chance to resettle. We would contribute that perhaps to a type of dizziness known as orthostatic hypotension, where we're simply not getting enough blood from our lower limbs up to our brain in time from standing. Syncope is when we lose consciousness and faint. And if we are having episodes of syncope, we want to be very, very mindful of that, letting our physicians know immediately if we're finding ourselves fainting and losing consciousness, because that would let us know that perhaps we're having a concern, whether it be centrally or in some cardiovascular realm, that we need to evaluate with some urgency. If you are actively fainting, I don't want to see you as a vestibular specialist. I want to make sure that your brain, your heart, and your lungs are functioning the way that we should before we explore your inner ear. Then there is vertigo, which is everybody's kind of favorite phrase to describe their dizziness, but is actually a really specific type of function. And that's where we feel like our world is moving around us, or we are moving around the room when there's actually no motion occurring. Vertigo is, like I said, one of the classic signs and symptoms of a true vestibular dysfunction, because our brain is being tricked to thinking that we are in motion when we are not. Unsteadiness can occur in a seated or standing position or when you're walking. And that's where we are having the sensation of disequilibrium, where we are feeling maybe we are having difficulty with directionality. We feel like we're being pulled around the space. We do not feel confident in our ability to get from point A to point B, and can impact us, like I said, in many different stages. When we're standing still, we might feel like we're imbalanced in some way. When we're sitting, we may feel like we're rocking or moving. So these types of descriptors, the way you describe your dizziness, can help drive where you will head next in your plan of care. And having the right terms can often be the big difference for the type of evaluation you're going to receive. When we think of vestibular testing, if you were to come to me with symptoms of vertigo, I cannot open you up to look at your balance organs. And you will be very happy about that, because I am very squeamish. That is why I'm not a physician that does surgery. I am an audiologist. And when we think about that, we have to use indirect measures to look at your system and evaluate it the best way we can, which is often through your eyes. Your eyes and your vestibular organs have a very, very close relationship. And we'll talk about that here in a moment. But in my ability to evaluate the way your eyes respond to different stimuli, it gives me an opportunity to speak to what your balance system is up to. Is it processing information the way that it should? So I'm going to go through a few vestibular tests, and some of you may have undergone these tests. And maybe during the test thought to yourself, what am I doing here? And how is this related to my ear? And I hope to open that up for you a little bit to give you a chance to think about the ways that we explore your system to determine how your balance system is functioning. When we think about your assessment of vestibular function, you may often participate in something called a VNG, or video nystagmography. This is an assessment where we're looking at your eyes with a pair of very fashion-forward goggles that record your eye movement as you are focusing on different stimuli, whether it be a dot shown on a screen or on a light bar, whether that dot is moving quickly or moving smoothly on the light bar. Are you looking at a picnic blanket as it passes by quickly? This type of test, the VNG, gives us an opportunity to look at how your vestibular, ocular, balance organs and eyes, vestibular organs and eyes, how that pathway is working together. And if there has been a change in your balance function, has your brain compensated, meaning made the adjustments necessary in order to help you maintain stability as you move through your day? When we think about our vestibular system, it's really just collecting information. That's its sole purpose. How fast are we moving? How far are we moving? Which direction are we moving? Your brain is what processes that information. And so we need certain pathways, certain parts of your brain to function appropriately in order to interpret that information the way that it needs to be interpreted for you to feel stable. And that's where the V&G comes into play. The video goggles are one size fits all typically, in like scuba goggles. So they don't fit anyone. And they're heavy on the bridge of your nose, heavy on your face. So if you've had a V&G, you probably remember that experience, and I hope that it was a positive one for you. What you may remember also about the V&G was perhaps you underwent something called caloric irrigation. Caloric irrigation is designed to stimulate your balance function, specifically the horizontal canal, in a controlled, temperature-based way. What does that mean? It means that we are going to either put water or air into your external ear canal and use the temperature of that water or air to excite or inhibit your balance organs on that side by changing the temperature. It seems very, very strange, but what happens is that with the change in temperature, because the water or the air is either heating up or cooling down your middle ear space, we are actually changing the function of your balance organ to one side and tricking your brain into thinking that you are turning your head. When your head is turning and your eyes have nothing to focus on, your eyes will actually make pulsing movement known as nystagmus that we can measure and register as function. The caloric irrigation, I will say, is not my favorite part of my job. I do not find joy in placing hot or cool water in patients' ears and causing them to feel some symptoms of dizziness. But it is something that gives me an incredible amount of information and is a very important piece of your V&G. If you've ever done a caloric irrigation, know that if you experienced a rolling or floating sensation, that is normal. No one has ever rolled or floated off of my chair. I am waiting for the day for that to occur. That will scare me, but people feel like they are levitating or moving around the room. When we are doing this task, the rolling or floating experience that you may have, I want you to know that it is controlled and it will stop. So a test like this is typically 2 minutes long, where the first 30 seconds, the water or air will be placed in your ear and you'll feel a gradual increase in your symptoms of dizziness, perhaps. And then for 1.5 minutes afterwards, we're recording your eye movements. And then as the temperature goes back down to normal, your symptoms of dizziness will subside. So I think there's often a lot of fear wrapped up in this test because nobody who feels dizzy wants someone to come in and make them feel worse, which I understand and respect. So know that if you have undergone a caloric irrigation, that's what was happening within your system. Another thing that we can do to evaluate your balance organs is to do something called a video head impulse test. This test is where you wear a pair of swim goggles that rest tight over your eyes and record your pupil as we move your head to the right and left as you focus on a target. This gives us information about, with quick movement of the head, are your balance organs able to coordinate your eye movements to stay focused on the target ahead? When we think about that vestibular and visual connection, the quick head movement should be registered by your balance organs. And through a specific reflex, you should be able to stay focused on a target. When I turn your head to the right and there's something ahead of you, your eyes should make an equal and opposite movement to the left to stay on the target of interest. In the abnormal system, however, the eyes and the head will move together. And then the brain will realize, wait, we're not focusing on what we're supposed to be looking at. And then the eyes will make a corrective movement to look back at the target of interest. In this test, we're measuring the corrective movement of your eyeball to determine, is it occurring in a normal or abnormal range? VHIT, or video head impulse testing, may be something your audiologist or physical therapist or physician includes within a larger battery of vestibular assessment. Another test that we can use to test your balance organs is something known as rotational chair or rotary chair. Perhaps you have had the pleasure of experiencing this one as well. It is like a teacup, but it's a scientific teacup. So what we do is we have you sit within the rotary chair and we record your eye movements while we spin you around at different speeds of movement. Those speeds of movement are controlled and influence your balance organs in a way where we are trying to elicit eye movements to see, are the balance organs responding the way that they should? When we are performing this task, moving your body to the right and left, we are often asking you a bunch of questions to keep your mind busy. And we do the same thing in the caloric test. Because the busier your mind, the better response we see from your eyes. And that's because we hope that we're distracting you from any symptoms of dizziness that you may be experiencing. But we also hope that you don't have the opportunity to slow down or suppress your eye movements to make your symptoms reduce or inadvertently change your response because you're focused on something else. Our goals with rotary chair are to plug in a piece of the system that is related again to that horizontal canal. So we think often of that horizontal canal movement when we're doing our testing. Rotary chair and VHIT are more tolerable than caloric irrigation. And perhaps as well, we don't have an intact eardrum, right? We can have perforations, we can have changes in the anatomy of the ear, or perhaps we don't have a functional ear canal. That's where we can plug in video head impulse testing or plug in rotary chair so we don't need to perform caloric irrigation. Video head impulse testing or rotary chair would be helpful as well in the case of evaluating children who may not be able to tolerate the caloric irrigation. Another test that is available to us to look at the balance organs, we actually use the muscles by your eyes, your inferior oblique by your eyeball, or your your sternocleidomastoid of your neck to look at changes in muscle response. And those are called vestibular evoked myogenic potentials or VEMPs. VEMPs are the only way that we can test your utricle and your saccule. So this is the only test that can give us information about the otolithic organs at this time. I bet in the path of my career, I will see changes within the way we are able to access this system. But as even within the past few years of me being an audiologist, the VEMPs have gone from something where we didn't do them too terribly often to almost performing them on every single patient. As we know that utricle and saccule function are very, very important. We actually use loud sound to stimulate your vestibular system. You may be thinking to yourself, well, what if I can't hear the sound? It actually has nothing to do with your ability to hear the sound being presented and everything to do with the vibration of the sound wave on the organ itself. The C-VEMP shown here is how the electrodes are set up for measuring from the sternocleidomastoid. In this test, we are exciting the saccule, getting the saccule activated to see a change actually in the neck muscle because it's all related. In the ocular VEMP, we are measuring from the inferior oblique under the eye. So we have the patient look up as we stimulate the utricle with loud sound in order to determine the response. These tests look slightly uncomfortable, I'm sure. And in the assessment battery for vestibular dysfunction, We are always trying to manage some of the, I'll say, strange presentation of our test battery with patient comfort. So there are modifications that we can make in order to accommodate you for whatever you may present with before you come into the appointment. And being thoughtful about other concerns. Perhaps you have cervical stenosis, or your neck muscle has limited range of motion for turning your head to the right and left. Perhaps we will not perform cervical VEM because I don't want you to lift and turn your head in that way and hold it for an extended period of time if we know that it's going to cause some level of discomfort for you within your test battery. Our final test, and kind of like the grand measure of how functionally you are able to navigate in space, is called computerized dynamic posturography. And computerized dynamic posturography is designed to tease your balance system as a whole. So visual, vestibular, and somatosensory. How do we do that? Well, we have you wear a harness like you're going pretty much skydiving. And that is to capture you if you fall. And we hook you up to this machine where you're facing a screen or you're facing a panel. And we manipulate that panel in front of you. We manipulate the force plate beneath your feet. We have you open your eyes. We have you close your eyes. We have you close your eyes while the force plate is moving beneath your feet. We do all these different metrics to measure how your body sways and moves to decide, okay, functionally, how has this patient accommodated for changes in vestibular function, changes in visual function, changes in somatosensory sensation, and how do we measure those changes to help us guide our therapy strategies? Often the answer for changes in vestibular function is to attend vestibular imbalance rehabilitation therapy guided by a physical therapist. A physical therapist will help us to determine how your system, visual, vestibular, and somatosensory, has changed in order to work with a change in balance function or change in vestibular function. And then from there, guide you through a series of exercises and activities to strengthen parts of that system and to build balance confidence in you moving forward. The balance system, coming back to it, we have talked here a lot about the vestibular system. And in thinking about the vestibular system and the ways to test it, it is a challenge often to just look at the vestibular system and not take into account that you are your whole person. If you've had changes in vestibular function or associated changes in auditory function, we can find that a shift in our ability to navigate the world safely or a shift in our ability to have auditory input can definitely influence our ability to move safely through space. But you're more than just your balance organs as you're walking around the world. We have to think about any changes in visual function that you may have experienced that can influence your ability to see clearly, or any changes in the sensation of your feet and ankles. And we're going to talk about that here now. So your visual system is key, as we discussed, to stay focused on targets as you're moving through space. And it seems very intuitive, but as you are walking through your home today, or going on a walk with a family member, or going on a walk by yourself, you are typically gazing ahead, looking at where you're headed, and there's world passing by you in your ambient vision, but we have some focal vision where we're focused on what we need to go to or where we're headed. When we're moving, our balance organs are responsible for holding our eyes steady, even as we're simply walking through space. We find in patients with changes to both the right and left balance organ, bilateral dysfunction, that they experience something called oscillopsia, where their eyes bounce while they move. And that's because their eyes don't physically bounce, but their vision bounces as they move because their balance organs are unable to hold their eyes steady. our goal is often in our test battery to test for this, to test the vestibular ocular reflex, because we are hoping that our eyes are able to stay focused on a target of interest as we are moving through our day. And our VOR, our vestibular ocular reflex, is dictated by our purpose, which is to keep our image of interest on the fovea of the eye, especially during quick movements of the head. So with that, our angular acceleration of our semicircular canals, our linear movement of our otolithic system helps to guide and refine our VOR. This is why patients with symptoms of dizziness related perhaps to a vestibular dysfunction, perhaps in some point in your life, you've been told you have a vestibular neuritis or a labyrinthitis of your vestibular system. Vestibular neuritis meaning there has been a change in the nerve, labyrinthitis meaning there has been a change in the vestibular nerve and the auditory nerve to one side. This is why when you move your head quickly, you may notice that your eyes shift and bounce to one direction. And it is because our VOR is not capturing, is not accommodating for the fact that our head is moving and our eyes have to reset a little bit. We note, however, that the role of vision is key in our balance function. And this is why when you're at the beach, if you've ever been in the water, I hope you have had the opportunity to do that, you notice that you drift away from your belongings. Like you'll look back and you're like, wow, my bag and my beach towel and my umbrella are way far away from me. This is not where I started since I've been in the water. I need to walk back towards my things. And it's because your visual system is so heavily weighted or has so much value to your overall balance that the movement of the ocean is something that your brain and your visual system is taking in. And as the ocean moves where you're at, you're pulled with the pull of the ocean. And it's because visually you're following the path of the waves, not on purpose, but it's just such an overwhelming visual landscape that your body has a natural pull and natural gravitation with the way that the water moves. If you've ever wondered why you drift down the beach. Your balance system, visual, vestibular, somatosensory, has that very important component, obviously, of being able to feel what is beneath your feet. With changes in our lower limbs, it is much more challenging to decide what type of surface we are on. You may have been diagnosed perhaps with peripheral neuropathy, a tingling and a burning of your lower limbs, where when we're standing on pins and needles, we find ourselves really pressing our feet into the ground or gripping our toes in order to decide what type of surface we're on. You may have had knee replacements or hip replacements, where we have gone in and physically changed the architecture of that space. We've given you a new joint. So the way that information is being sent from your feet all the way up to your brain is now traveling through new pathways. I also think our somatosensory system is something that we need to be thoughtful of in regards to just general foot care. And this is something that I thought about more in Nebraska. So when I was in Nebraska as a student, I actually would go to a foot clinic, and it was for a project I had to do for a class. And I found that there was this foot care clinic in Nebraska, and it really opened my eyes to just how important it is to be able to cut your own toenails and take care of your own feet at the end of the day. And it may be something we take for granted, but if our hands change in their sensation or become less able to grasp the toenail clippers because of arthritis, or we are unable to bend down and forward due to spinal concerns to reach our feet, our inability to take care of our feet can actually change our gait and balance, where if our toes hurt, our feet are in pain, we may not walk the same way that we did before. We maybe walk more gingerly or walk more slowly, and that will influence our overall balance function. So this foot care clinic would actually provide free care, free toenail, like free pedicure type of situation for individuals in the community that were unable to take care of their feet. And so with that, the ability to care for one's feet and to have literally put your best foot forward on a day-to-day basis is just as important almost of wearing your glasses when you're supposed to when you're walking, or being mindful of any things that may influence your balance function as you move through space. Our equilibrium system, when we are talking about the balance system, is very similar. We are taking in information not only from our lower limbs, our soles and our joints, but also from our neck. How we hold our head in space is related to our balance system to some capacity. Obviously, we can have cervical concerns and neck tension and neck pain, which may shift the way we hold our head, but then that causes a change in our vision, and it causes a change in the way that our head is registering where we are relative to gravity. You may find, or you may have experienced, if you've had an acute or a quick change in your balance function or severe vestibular input, that your head is tilted to one direction. And then as time passes, your head returns back to normal. That tilt or that change is related to the sudden change in vestibular input, where our vestibulo-colic reflex no longer really knows how to hold our head, and our world is at a degree of shift. This is related to a reflex pathway known as the vestibulospinal reflex, and that allows us to stabilize our body as we move through space as a whole. And that's what elicits our fall reflex. We know when we fall, and I stick my arm out like this, if I'm falling to the right, I'm going to extend my arm out and try to stop myself from coming to rest on a lower level or coming to rest on the ground. And that's reflexive. The ability to initiate that movement, initiate that stopping action, is designed from signals within our otolithic organs, designed from the interpretation of the acceleration. And if we don't know that our head and body is moving, then we can't elicit that reflex to save ourselves from a fall. We try to do all kinds of reflexive movement in order to stabilize our body. So in a day, we might use what we call some hip action, where we find ourselves falling, so we tilt our hips forward or tilt our hips back in order to maintain balance. This is what gymnasts are using when we are standing on a balance beam. I'm not a gymnast. I don't know why I said we, but I've never been successful at that. But we have our riding reflex, where we're trying to keep our head stable as we are tilting forward and back and using our hips to keep our head stable, or we use our ankles, little movements of our ankles in order to keep our body stable as we're standing on different surfaces. We want to keep our head level. That's our ultimate goal. Even when you are standing still, you may feel a subtle rocking of your body, and that is related to just our normal body sway, how our body is fighting to stay upright and using our ankles in order to maintain that stability. These pathways allow us to see the visual field in front of us clearly, keep it stable with the VOR, allow us to maintain stability of our head so we don't have too big of a tilt or too big of a pull with the vestibulo-colic reflex, as well as maintain upright stance with our vestibulospinal reflex. We talk about all of the different types of reflexes, this triangle, visual, vestibular, and somatosensory, that allow us to maintain upright stance. But there are so many different things that can influence each of those systems, or all of those systems as a whole. We are moving through our day, not just as these different parts and pieces, but as a human. So there are other things that are going to happen to us in our experience that will change our balance function. They can include affective disorders or psychiatric conditions, such as depression or a fear of falling. If we are fearful of falling, we are less apt to push ourselves in activities that we may find challenging. But if we're not pushing ourselves, then our body will change. And when we go back to do it again, we may not be able to. There are infectious diseases, and I touched on diabetes in regards to peripheral neuropathy, changes in the sensation of our feet and ankles. There are concerns regarding cardiovascular disease. Do I have orthostatic hypotension? So every time I stand up quickly, I have that blur and that lightheaded sensation. So I have to teach myself to stand slowly and to wait before I take that first big step in the morning. Or sensory disorders, such as hearing loss, peripheral neuropathy, or visual impairment. And we'll touch on hearing loss here in a moment, how that's actually thought to be related to some type of some type of imbalance or increased risk of falls. There's also the thought process with neurologic disorders, obviously our ability to coordinate all of this information appropriately. And within that, vestibular disorders. If you've ever been diagnosed with vestibular neuritis, labyrinthitis, benign paroxysmal positional vertigo, Meniere's disease, migraine actually, or something that is clearly vestibular, which would be an acoustic neuroma, with acoustic neuroma resection, where we know that we are surgically going into your system and changing your balance function based off of our ability to remove the acoustic neuroma from your system. And how did your body respond to that or compensate in order to improve your balance? We have musculoskeletal disorders or other acute illness like hospitalization. If you've been hospitalized for an extended period of time, we often see a decompensation in our body. So the organization of visual, vestibular, and somatosensory can be compromised. These changes can occur related to the disease process, but also occur in changes related to age. We see natural shift in our vestibular system relative to the aging process. And we all want to age in a healthy way. And I think that's where sometimes I'll speak with patients and they'll talk about how they've accepted multiple falls, or they've accepted kind of a fear of falling as a part of their aging journey. When in actuality, there is healthy aging related to balance function, and then components that are not necessarily typical. Multiple falls are not necessarily typical related to our aging process. A fear of falling that is so inhibiting that you no longer do the activities you enjoy is not necessarily part of our natural aging process. So how can we support you and guide you to the right resources so we can continue to age in a healthy way related to our balance function? I have a few more slides here and I'll be mindful of our time so we can capture some questions. But I want to talk about falls, because falls are the functional outcome of vestibular changes that can be most devastating. When I talk to patients about falls, we are cognizant of the fact that falls are, in their purest definition, a sudden unintentional change in position causing an individual to land at a lower level on an object, the floor, or the ground, either as a consequence of sudden onset of paralysis, or other than as a consequence of sudden onset of paralysis, epileptic seizure, or an overwhelming external force. So a fall is when you unintentionally come to rest at a lower level, which can be as simple as I tried to get up from the chair in the waiting room and I didn't have the strength and I fell back down into it. That is a fall. When talking with patients about falls, though, we are talking typically, I feel, about two different things. Where when patients discuss falls with me, they say, well, I haven't fallen at all. And we are thinking probably along the lines of, I haven't had a devastating fall where I've tripped and fallen on the concrete, or I've injured myself in some way. But myself as the provider often think, well, I watched you actually fall right now when we tried to get up out of the chair and you came back down into it to try to move to the next test. So thinking about falls as they can be small events. They don't have to be devastating in order to be a change or a shift within our system that we need to be mindful of. Aging adults and falls, we know that individuals over the age of 65 have the highest incidence of falls as compared to other age groups. And non-fatal falls, falls where we are injured, often result in cuts and bruises and fractures and traumatic brain injury. But a non-fatal fall is still a fall that can have devastating consequences. And we know perhaps individuals within our friends group or within our family who started to sustain falls or multiple falls and injure themselves in a way where we had a hard time coming back, or we had a hard time negotiating our way back to the activities that we enjoyed before. And so every fall, whether it be small or large, is important to keep track of and help manage. And falls unfortunately cause 60 unintentional deaths per every 100,000 persons. So being thoughtful about someone perhaps who is having multiple small falls, or who is perhaps living in a space that's more cluttered or having difficulty navigating, it's always important to think about falls as the unintentional outcome, poor outcome of that or changes in balance function. We're thoughtful though about hearing loss and imbalance because this is a link or a piece of the puzzle that more attention has started to be paid to over the past few years. Because we find that individuals with hearing loss are more likely to experience a fall. There's a study done out of Baltimore by Lynn and Ferrucci, and they talk about for every 10 dB increase in hearing loss, there's a 1.4 increase in the odds that you will sustain a fall. And there's a lot of working hypotheses about this, like why? Why are we thinking that there's this hearing loss relationship to falls? Well, from our first slide, many slides ago, we saw the auditory and vestibular system so close together. They are neighbors. They are within the same system. They are anatomically, in a way, linked. Are we seeing changes in cochlear function that are related to parallel changes in balance function regarding the vestibular system? With hearing loss, are we having changes in our ability to monitor the environmental noise around us, which can often give us cues about our relationship to other pieces of, or cues about our relationship to other components of items within our space. If we've had changes in hearing, it can often be difficult if we are experiencing greater changes in hearing to hear perhaps our pet in the environment around us, the sound of our dog's toenails across the floor, the sound of the movement of the door of our dishwasher when our partner is behind us and turning and falling into them. We also think that with changes in hearing, we are dedicating a lot of cognitive resource to understanding the sounds around us. And because we are dedicating a lot of cognitive resource to understanding, perhaps we're not dedicating as much cognitive resource as we need to organize our balance function appropriately. So these are all kind of exploratory ideas that the science community is looking at to explore in a deeper sense, because obviously, as we continue to age and grow as a population, changes in hearing and changes in balance function will become more prevalent. So there, and on my final slide here, some intrinsic and extrinsic risk factors that can influence our balance function as a whole and influence our risk of falls. Intrinsic being things within us that we are bringing to the table as a person, extrinsic being things around us or happening to us that are perhaps modifiable. So looking at these two components and thinking to ourselves, okay, what can I change internally and what can I change around me to reduce my risk of future falls? And being mindful of these intrinsic and extrinsic risk factors as you're moving through your day in order to prevent a fall related to your balance function. So feel free to ask me questions now and to contact me if you have questions. I put my email on the slide here, but if there's any way today when you're moving through your space that you can appreciate how your brain, your balance organ, your vision, and the sensation in your feet and ankles are working together, it can just help you be more thoughtful about how complex this relationship is and how it's really kind of amazing at the end of the day that we're able to move through from point A to point B in a safe way. So thank you. Thank you for having me.
Thank you, Dr. Bassett. What